Hi, it's Christina Wang, and on behalf of the American Society of Retina Specialists, I'm reporting from the annual meeting here in Boston. It's my pleasure to be here today with Dr. Carol Shields, Professor and Director of the Ocular Oncology Service at Wills Eye Hospital. Dr. Shields, thanks for being with us today. You gave a talk looking at the correlation of cytogenetic abnormalities and clinical features of uveal melanomas in 1,059 patients. We've really entered an era of personalized medicine, and in your large series, you sought to determine an individual's rate of uveal melanoma-related metastasis based on their individual tumor's cytogenetic profile. Can you tell us a little bit about what you found?
Sure. So the whole field of ocular oncology has evolved now towards biomarkers and cytogenetic profiling of tumors. And with uveal melanoma, we basically search for 3 known mutations in chromosome 3, 6, and 8. And we found that chromosome 3 and chromosome 8 are deleterious mutations. They cause a higher risk for metastatic disease, whereas chromosome 6 is not as deleterious. Some even say it's protective. And we found, using these 3 chromosomes, that we have 52 different genetic profiles. And we can stratify a patient's exact risk based on the number of mutations and the chromosomes that are mutated. For example, if a patient has only chromosome 3 mutation, they may have a 20 times greater risk for metastatic disease. But if they have a chromosome 3 and a chromosome 8q mutation, the risk escalates up to about 120 times greater risk for metastatic disease. So this allows us to understand who's at risk for metastatic disease and hopefully take those patients at high risk and treat them prophylactically to prevent metastatic disease.
So Dr. Shields, based on these findings, are you currently recommending to all of your uveal melanoma patients that they receive a fine needle aspiration biopsy with this type of cytogenetic analysis?
Yeah, for sure. So we generally recommend for all patients with uveal melanoma to have cytogenetic testing. The way we do it is at the time we treat their melanoma with radiotherapy, we do fine needle aspiration biopsy through the pars plana, through the vitreous, directly into the tumor, sample the tumor, just a few cells are retrieved, and it's sent to our genetics lab. We think it's important for all patients to have analysis because we can stratify them as high or low risk. Not every patient wants analysis. There are some patients who are elderly and they don't feel it's necessary for them to have analysis. And there have been studies that have shown that there's a little bit of a psychological adaptation to knowing that you have a bad outcome. Some patients have anxiety and regret that they ever did it. But in most cases, patients will agree to have cytogenetic analysis. It's kind of smart medicine. It allows them to understand what is their true risk, and if they are at risk, then we can systemically treat them and hopefully prevent metastatic disease.
So you touched on this a little bit earlier, but for a patient who receives a less favorable tumor cytogenetic profile, how are you altering their management? Are you sending them for more frequent metastatic surveillance?
That's a really good question. I will twist your question a little bit because I like to do the genetic testing to find those with good results. And for those that have good results, that is low cytogenetic mutational profile, it's peace of mind. They feel and they know that they're at lower risk for metastasis. Now, to answer your question, those patients that have high risk cytogenetic profile, that means at risk for metastasis, we will do more frequent imaging, and we work with a large oncology team, specifically a large melanoma oncology team that will enter them into prophylactic therapy to prevent metastatic disease because we know they carry such high risk. And we're using medications like sunitinib, also known as Sutent. It's a protein kinase inhibitor. We're using valproic acid for certain mutations, and we're entering into the field of immunotherapy. And if you read the dermatology literature with cutaneous melanoma, immunotherapy is very exciting and actually has cured patients of metastatic disease. So we're doing some alternative therapies with immunotherapy, and it has been favorable so far.
Well, I can imagine that having this type of information can be so extremely valuable to some patients. Congratulations on your work. Thanks for joining us today. And this is Christina Wing reporting for ASRS Updates from the Field.